morning. This is Dr. McDaniel at GYN Corner here on Facebook Live and on YouTube. Yesterday I spoke about endometriosis and I'm continuing that talk today. So as a recap, endometriosis is a disorder or a condition where the tissue that is lining the uterus to cause a menstrual cycle every month is microscopically, so you can't see it with the naked eye, but sometimes macroscopically, so you can see it with the naked eye, scattered throughout the body of an individual. Predominantly it will be in the pelvic abdominal cavity, but sometimes it will be seen in faraway places, so the brain, the lungs, spinal cord, lymphatics, so throughout the body. We don't know specifically or 100% why some women get endometriosis and some don't, but approximately 15 to 20% of the female population is thought to have endometriosis. We don't really know how it occurs, but the thought is that it's predominantly from retrograde menstruation, meaning that when the menses occur, the blood and tissue builds up in the uterus, it flows out through the cervix, but for some individuals, a small portion of it will flow backwards through the fallopian tubes and then spill out into the pelvis. It's also thought to have a hematologic or lymphatic spread similar to a cancer, whereas some of the lining that builds up in the uterus gets or infiltrates or gets into the blood system and the lymph system and goes out through the bloodstream and through the lymphatic system, and that's how the faraway regions are occurring. So the brain, lungs, spleen, liver, outside areas like that. Endometriosis is not a disorder that will cause death for anyone, but it can, so it's not a disorder that causes mortality, but it can cause morbidity, because the definition essentially is menstrual pain that is disruptive to activities of daily living. That being said, it means that when someone has their menstrual cycle, pain medicine doesn't help or barely takes the edge off. Despite all efforts to alleviate the pain, they're doubled over in bed, incapacitated, and cannot function for 1 to 2 days or more during the menstrual cycle. Endometriosis is thought to be inherited, so if someone's mother has endometriotic symptoms, then her daughter or daughters will most likely follow suit. We don't have any other risk factors for endometriosis. We don't have any way to diagnose endometriosis, so there is not one specific diagnostic test that can be done. That being said, what some women will be requested to do is, if they have severely compromising menstrual pain, we always recommend that they have an ultrasound or sonogram performed, and that's to assess if there's any macroscopic evidence of endometriosis, so cysts that occur due to the endometriotic implants. So wherever that endometriotic tissue or the lining inside the uterus is the endometriotic tissue, wherever that has occurred or fallen or been placed in the body, with each cycle, it too is stimulated. That stimulation causes microscopic bleeding, and given time or given enough tissue accumulated in one location, it can cause macroscopic bleeding. So we can see a pocket of blood built up in that location. A pocket of blood is called a cyst, and if it's a small cyst, which is considered 3 centimeters or less, so the size a little more than an inch or less, it's called an endometriotic cyst. If it's more than that, it's an endometrioma. And we can see evidence of those cystic changes or endometriomas on an ultrasound or sonogram. The most common location for an endometriotic cyst is on the ovaries, because the fallopian tubes lie directly over the ovaries, so it's thought that with retrograde menstruation, the majority of that endometriotic tissue gets dumped right on the ovaries. The second most common location is behind or in front of the uterus. So we will often see cul-de-sac endometriotic cyst or the ovarian endometriotic cyst. If a sonogram is done and no cystic changes are noted, there's no abnormalities or aberrations seen on ultrasound, then we assume that the endometriotic changes are microscopic. That's why we can't see them. If we do see cystic changes, then that's a definite 100%. If the cystic changes look like endometriosis, then that's the diagnosis of endometriosis. We call those cysts endometriotic cysts, endometriomas, and years ago we used to call them chocolate cysts, and that's because as the blood gets old, it's sitting there pooled, it oxidizes, it turns very, very dark, and it looks like milk chocolate. Now, the other test that we used to do, it's not strongly recommended now, but we used to do what we call an exploratory laparotomy or an exploratory laparoscopy. The laparoscopy has superseded the laparotomy. So the laparotomy is an incision, a cut either sideways or lengthways on the lower abdominal, upper pelvic area for surgery to look inside the body and assess if there's any evidence of endometriosis. And as I stated yesterday, endometriotic implants are sometimes seen as what we used to call powder burns. So brown, yellow, gold, purple, blue, little speckles or spots or bubbly areas or scarred tissue looking areas on the lining of the abdominal cavity, the pelvic cavity, on the lining of the intestine, sometimes the bladder, the ovaries. So we just look through the pelvic abdominal cavity, see if we saw any evidence of those pathognomonic scarring. That got replaced with laparoscopy. Laparoscopy is the camera surgery. So we put a camera in the belly, do the same thing. Just explore, look around, see if we can discover any telltale signs of endometriosis. If we saw them, we would remove those areas by biopsy. So we'd biopsy a few areas. If there were a lot of them, we'd biopsy a few samples to send to the pathologist so that they can confirm that that's truly what it is, endometriotic implants. And then for the remaining areas, we would destroy them. That's called ablation, and we destroy them either by burning them, cautery ablation, or with laser, which is another form of burning. That's not done very often anymore. It's done as a second tier form of potential treatment rather than diagnosis now. I'm going to end today's session there with the information about the risk factors, assessment, and diagnosis. Tomorrow I'll come back and most likely finish off the talk on endometriosis. This is Dr. McDaniel in Midtown Manhattan. This has been a presentation, the second presentation. Yesterday's was the first one on endometriosis. And today's Friday, May 31st. Tomorrow's June already. This is GYN Corner. Please check out the YouTube channel. It's also called GYN Corner. And if you're in the area, Midtown Manhattan, or in the tri-state area, come on by the office. We're here in Midtown Manhattan, around the corner from Penn Station and Macy's. We take walk-in hours every day that we're open. Just call for the walk-in hours. Information is on the Facebook and the YouTube page. Everyone have a great Friday, and see you tomorrow. Thank you.